This is Leonard Kish with healthit.tv, and we're happy to have here today Andy Altorfer, who's the CEO of CirrusMD, telehealth and virtual care company here in Colorado that's starting to have some really great traction, and Mark Lassaux with Quality Health Network in Western Colorado, Grand Junction. Hi guys, how you doing?
Good.
So you guys have been working together, I think, a little bit over a year now. Mark, you're part of Quality Health Network, as I said, that's HIE in Western Colorado. Tell us what you've been doing with QHN, because I've seen you as really one of the more progressive HIEs that I've run across. So what have you been working on the last few years in terms of data exchange on the Western Slope?
Yeah, well, thanks for that compliment. We'll definitely take that as a compliment. It's a lot of hard work, HIE type work and activities. But you know, we started out fairly small in 2004 is when QHN was formed, and started out locally here in the community and built it up from that. Lately, in the past several years, we've been having good exchange with our state HIE partners. Korea, we're exchanging data with them now. We're also exchanging data with our neighboring states, Utah and Arizona, growing that out, and we're also now able to accomplish more advanced use cases like we're talking about today with Andy and their organization for moving data securely to where it needs to go when they need it. And so I think we've had a lot of success, and things are progressing for us as an organization, and looking forward to more of that too, moving ahead.
Great. And Andy, tell us a little bit about CirrusMD and how you came together to work with Mark in a telemedicine context. This conversation is about integrated telemedicine. You guys, I think, have a pretty unique perspective on and really focus on value-based telemedicine, and the requirement then that's all linked back with primary care providers and so on. So tell us a little bit about CirrusMD and how you came to work with Mark.
Sure. So CirrusMD is a virtual care company that's focused on creating a much more integrated and scalable approach to telemedicine than what we've seen from a lot of the vendors that people may have heard of. And we're trying to do that in the context of value-based care. One of the critical components to making value-based care work is having good data continuity and having the ability to successfully treat patients in place, but also engage the brick and mortar when that's needed. One of the things that makes CirrusMD unique is we use a text messaging first workflow, and then bring in other communication modalities like video as necessary. And then we are very focused on creating data continuity between the virtual encounters and then the brick and mortar physicians through partnership with groups like QHN. We are operating in a number of regions throughout the U.S. right now, and are under contract with just short of 1 million covered lives today.
And so you're working with one of the payers out on the Western Slope, which is so your business model is really based on working with payers or some kind of at-risk provider or employer. Is that right?
That's correct. Through regional payers and integrated delivery systems that are typically taking risk under some form of their own health plan or under an ACO contract. So working through a variety of value-based care type organizations. We were introduced to QHN through a mutual client of ours who was interested in how to better integrate the data from our virtual encounters and provide notifications back to the primary care physicians and the care managers for a Medicaid population who are in their network. And so it's really an opportunity for QHN and CirrusMD to work together to bridge the gap between virtual encounters that are taking place on our platform and the physical establishment that is already linked together through the QHN network.
So let's walk through a little bit about how that happens. So somebody who's in this network, they have the CirrusMD app, so it's a private kind of text messaging first platform. They reach out to a physician and they have an encounter through text message. You know, a sore throat, maybe they get sent to urgent care, or maybe they get a prescription or something like that. And then, Mark, how does that information, if that's correct, wind up back in the the primary care physician's office or their main physician's office?
Yeah, so Andy mentioned the data continuity component of this, and that's really what QHN provides in getting that information to the bricks and mortar physicians that need it. So I kind of mentioned how QHN started kind of locally in the community, and we've spread out to the entirety of Western Colorado. We have 94% now of the medical providers in Western Colorado connected up and participating in QHN in some way, shape, or form. So the way that that happens then is as these patients are being having encounters within the Cirrus tool, Cirrus is sending us that message using a standardized format, and we're taking that and we're determining a couple of things. First, who it's about, right? Which patient it's about, and matching that patient up so that we are sure that we're tying that encounter to the correct patient, so that when we get it to where it needs to go, they know who it's about. And then we have to identify where it needs to go across our network. And our network, it's pretty much Western Colorado, the Continental Divide to the west, and the San Juan Mountains to the north. So they do these encounters. Cirrus is sending that data to us. We're looking at it, understanding who the patient is, and then the providers that are associated with that encounter, and then we're pushing it to them in the format that works best for them. I think that's one thing that when you're thinking about delivering data this way is, and one of the real values we provide as an HIE is we're getting the data to them when they need it, where they need it, and how they need it. And that comes in from a workflow perspective all the way to a systems perspective. There's different ways that we need to get that information to them using different methods, but that's generally how we do it.
So Andy, how is that? So that's pretty different than these kind of one-off encounters that most of telemedicine provides. What makes this workflow unique, and what really enables that in your business model?
Sure. There are a number of aspects, and again, talking about continuity, it's a dedicated, staffed approach versus some disaggregated national group of doctors who are picking calls out of the ether. There's a local group of ER doctors who staff the service. They have access to the medical record through QHN. They also have a lot of demographic and other information about the patients directly pulled into the platform through a single sign-on. So they have a really good understanding of who the patient is that they're treating. And then post-encounter, all of that information gets fed back through QHN back to the primary care docs. And additionally, the virtual doctors have access to the patient's PCPs and specialists and others in the community as well. So it is they're able to call the patient's own doctor if they feel that that's warranted and necessary, and they do in fact do that. The other unique thing about this workflow is that about 85% of the encounters are done via text only. There's not really any other telemedicine service on the market that has any scale anyways. That is really a text messaging first workflow, and that gives us a really unique opportunity to have a lot of unstructured data about a patient and throughout a patient encounter that we can transmit over QHN and arrange that to them in the most appropriate manner for them to disperse out through their network.
So a lot of people, I think that's one of the most shocking statistics, that you can really do 85% of this via text. Do you have a sense how many of those people would have gone to an urgent care or some other in-person bricks and mortar kind of an encounter?
Sure. So the breakdown is about 15% of people coming on would have otherwise gone to the emergency room. About 25% would have gone to an urgent care. And then the remainder is split to people who might have gone to their primary care doctor or may have used Dr. Google or sought some other means of care where, or just let it go because they didn't have an effective place to get treated. But 40% represents diversion from high-cost points of care.
Wow. So that's when you look at physician time, it really helps to scale, both because I think one physician can handle a lot of patients via text, but then also you can really get the more high priority cases seen, where they're needed in the bricks and mortar setting.
Well, it scales significantly better due to the asynchronous nature of text communication. One physician can manage anywhere between 7 and 8 encounters at the same time. So when you think about telemedicine as industry scaling, one of the things that hasn't been well answered thus far, really by anybody but us, I believe, is that if you're going to have a phone-only or a video-only workflow, it doesn't scale physician time. By bringing in an asynchronous communication pattern, for the first time you're able to be a force multiplier for an individual physician to cover a larger panel of patients, which ultimately leads to significantly lower costs, while also maintaining incredibly fast response times. Our average response times are under a minute, and we service level to under 3 minutes. So it's a very interactive and engaged way of delivering patient encounters.
And you get direct access to a physician, right? You don't have to go through a nurse practitioner or somebody else. It's actually a physician that's on the other end, right?
Correct, and that's something that we see a lot. I've just gotten back from the ATA, and there's a lot of people pushing either bot-driven workflows or questionnaire-heavy workflows, all kinds of ways of trying to treat people without ever getting them to a doctor or creating a bunch of barriers between a patient and a doctor. And some of the larger managed care organizations we've worked with have actually realized a lot of those intermediary workflows just serve to frustrate the patient, slow down the patient being able to get to a care plan, and actually end up costing more by putting so many intermediary layers in between a patient and a doctor, when really what the patient wants, when somebody comes into the doctor's office or somebody comes into the hospital, they want to see a doctor. And virtual programs really aren't any different. And so we represent the fastest path of access from a patient straight to an ER doctor who's going to be able to triage them and connect them to any brick and mortar services that they may need, or triage them to the appropriate point of care if they aren't able to successfully take care of the issue virtually.
So, and it's really an extension then of primary care, and it's maybe less of a threat to primary care. I think a lot of physicians today feel threatened by telemedicine, but this is actually helps on both ends. It helps them see the patients that they need, but also gets the patients that need simple things done kind of quick access to a decision.
Sure. We're in an environment where there's a physician shortage and long wait times and overpacked clinics. That's a problem that needs solving, and that's a problem that directly leads into why we have so many unnecessary ER visits. If we can create a mechanism through partnerships with organizations like QHN and through structuring our provider panels and overall business opportunities in a manner where we're actually feeding the patients back into the appropriate points of care within the existing system locally, it's a new point of access that's coordinated virtually with all of the physical points of access that already exist. So it's really an extension, it's a new point of access, and it shouldn't be viewed as a threat. And in most cases, it's not viewed as a threat. Once it's, on the surface, many doctors are hesitant or resistant against telemedicine services that they view might be stealing their patients. When you tell them this is actually a means to be more sticky with your patients because you're providing continuity and you're funneling the patient back to their own doctor, that makes it a very non-threatening thing.
Yeah. And there's a couple more points I want to hit on. One is the documentation. So this is not billing based. So this isn't an encounter via Cirrus and fed back to the HIA is not going to be a lot of billing data or different kinds of billing codes. It's going to be more clinical. So Mark, can you tell me a little bit about does this differ in any way from other kinds of information that you're receiving from EHRs or other kinds of encounters?
Well, no. I think what's important about this, and when we're thinking about one of the big values we have with HIE infrastructure, common HIE infrastructure, is it's imperative that folks know about where their patients are appearing and generally what happened with those patients during that encounter, during that appearance. And so from that perspective, you know, Cirrus, with their innovative tool and their virtual abilities, they're able to have another connection point for that patient to appear and get some care that they need. And then when they send that data to the HIE, then we're able to move that data out to the care teams that are normally associated with that patient during the normal hours, and to help them get there. I think that's foundational to all of this, is kind of that concept of, if we're going to treat our patients, our patients better and well, the people that are associated with the care of that patient have to know where they're going and generally what happened, and then we can coordinate better after that about the next steps for them. So, you know, that's really, we strive first and foremost is to understand that across the community, where patients are appearing, where they're getting care, and then generally what happened, and so that the care teams that are associated with them can make the best decisions.
Great. And so it really helps create more of a complete picture, or more longitudinal view of the patient.
It just helps fill in the gaps and give that more complete picture for when they go and they follow up after, and nobody has to go and make calls and get the data faxed or sent over in a folder or whatever. You know, we're moving this data around securely to those that have the relationships securely and electronically.
So that leads to, you know, if you can really track people longitudinally, and you're dealing with a Medicare population, Medicaid population, do you get a sense, or do you have any data on how you might be influencing population health yet, or even, you know, individual cases? Do you have a sense for that?
So we do have a really good sense around use cases and individual cases, and are seeing this grow throughout a population on an anecdotal basis. A lot of we survey all the members post-encounter, and a lot of people who have an encounter say, well, I actually heard about this through my friend. They've done this before, and now I've gone and done it. And it really is, particularly within a Medicaid community, it needs to be a very grassroots, all hands-on-deck communication pathway, because in many cases we don't have an email address, or we don't have other critical outreach information, and people's addresses shift a lot. So, you know, I would say we're still in a bit of an early days situation to say, how has this new type of access broadly impacted the overall population's health? What I can say is that within that population, utilization continues to grow. There is a lot of individual-to-individual communication that is being used to help raise awareness. And then anecdotally, we also know that, you know, valuable care is being delivered. The payer was able to see an ROI within the first year of the service being launched, and, you know, and at utilization levels that are much higher than you see from the teledocs of the world. And it continues to grow on a month-on-month basis. So I think we are starting to certainly make an impact, but to say that this has fundamentally altered the health of the overall population, we're probably still a little early on.
Well, I know that you probably haven't seen, it's still probably a little bit too early to see this either, but, you know, this gets to the point where it could be a real competitive advantage. I mean, when I hear your story, I really want to switch health plans so I have access to this.
You know, Leonard, I would point out, I've used this twice for my two boys. I have an 8-year-old and 11-year-old, and from a parent perspective, this type of access is, you're right, it's just so reassuring. It saved me a weekend, actually. One night we were headed out of town late on a Friday night, and my 8-year-old son comes up to me with a swollen finger and, you know, red and stuff coming out of it. And 5:45 at night, I'm thinking, what are we going to do? And so we dialed up. We did this solution, and saved our weekend. Literally, it got us on the road, and out we went. And we still had a great weekend. So. Right,
and it. You know, we're traveling for soccer tournaments and things now, and it would be just great to be able to, if, you know, God forbid something happened,
that's it, yeah,
just be able to text, you know, from anywhere.
Reassurance, yep, reassurance, and help you get what you need on off hours. So.
All right. Well, thanks so much, Andy. Thanks, Mark. Best wishes to both of you. I just hope this continues to grow and I have access to it very soon.
Yep, we do as well, and thank you for that.
You bet.
Thanks.
Thanks. Take care. This is Leonard Kish with HealthIT.tv with Andy Altorfer at CirrusMD and Mark Lassaux at Quality Health Network. Thanks.